All right. Why are we excited about today? We're excited about today because this is the day that we really start talking about kind of the basic fundamental concepts of epidemiology, the things that you really, really need to know in order to understand epi. So remember last week we talked about epi can kind of be roughly divided into descriptive epidemiology and analytic epidemiology. Today we're really going to talk about descriptive epidemiology, which is the fundamental not only of the field of epidemiology, but a lot of healthcare research in general. Descriptive epidemiology, we're talking about who gets the disease, where they get the disease, and when they get the disease. We're talking about the disease distribution. So we can say who, what, when, and where, but really in descriptive epi, we typically refer to it as the person, place, and time of disease. These are the three important categories that we have to talk about when we're talking about descriptive epi. So person really means who's getting sick. Is it just women? Is it just men? Is it just children? Is it just older adults? Who's getting sick? Place is referring to literally the geographic distribution of disease. Where are people getting sick? Are we having, is it just people on the campus of SLU that are getting sick? Or is it distributed across the United States? Is it distributed across the world? Where are people getting sick? Are people in rural areas more likely to get sick than people in urban areas? All of these things we have to consider when we talk about place. And then time is when are people getting sick, right? So it's talking about the chronology. So is it cyclical? So things like asthma has cyclical natures a lot of times. So when the spring comes about, you start seeing a lot more ER admissions for asthma, right? Because all of the pollen's out and everybody starts having asthma attacks. So are there cycles and patterns? Is it something that you see that's consistently bad and then you see a spike? And when did that spike happen? All of these things are things we have to look at when we're trying to describe the distribution of disease. So when we're talking about person, these are the things that I mentioned. This is not an absolutely totally inclusive category here, but these are some of the characteristics that we look at when we're trying to describe the person aspect of descriptive epidemiology. This is why when you look at the CDC website, if you look at the breakdown of colon cancer within the United States, you see that they give you little graphs broken down by age. They see that they give you things reported by gender. All of this stuff is really describing who is getting sick. Skipped place. And then again, these are just some of the general things we're looking at when we're talking about place. We want to know which areas have the lowest concentration of disease, which areas have the highest concentration of the disease that we're interested in. Are these rates differing based on geographic location? If a population moves from one location to another, do their rates of disease change? So, for example, the incidence of colon cancer in Japan is very low. Within one generation of moving to the United States, the Japanese have the same rate of colon cancer as the rest of the population of the United States. So the geography is playing a difference, probably due to cultural factors and the fact that they start eating a lot more McDonald's when they get here. I don't know. But so there's who is getting sick and where. And then finally, skipping over time. So are the disease rates changing over time? So we can look at it in terms of infectious disease epi, where we're looking at small epidemics or outbreaks and when are those occurring. But we can also look at it long term. So the incidence of diabetes has been steadily increasing for the past 20, 30 years, something like that. And so we can look at the long-term trends and incident prevalence. We can look at cyclical trends like I talked about with asthma. We can look at age, period, cohort effects. So interesting, I don't know if any of you have heard the new CDC recommendations on hepatitis C screenings. If you listen to NPR, it's been all over NPR and various other places. But basically the new guidelines are that anyone that's in the baby boomer cohort is recommended that they be screened for hepatitis C because people within the baby boomer cohort are 3 times more likely than the rest of the population to have hepatitis C and not know it. There's other issues going on with that, but so you can have period birth cohort effects. So people that were born at a certain time are more likely to have a certain illness for various reasons. All right. So we need to make a distinction between diagnosis and defining disease for epidemiologic research. So when we use the term diagnosis, we are really talking about in a clinical setting, you're sitting there with your physician, do you have a certain illness based on your clinical diagnostic information? So this is a complex scenario, right? Your doctor does, you don't just walk in the door and your doctor's like, you have colon cancer, right? You walk in the door and your doctor says, sits down and listens to all of your symptoms. They listen to all of your signs. They give full medical history, hopefully. You have time to do that sort of thing. They then order a bunch of tests, and then based on those results, they order a bunch more tests. All with the hope of you finally coming out with a diagnosis of them telling you exactly what is wrong with you as an individual. In epidemiologic research, we don't have that luxury because we're talking about population. So we can't sit down with every person that we think might have a disease and go through this long clinical process. We usually have to have some other way of identifying and defining whether or not we are going to consider a person to have a disease in our study for our research purposes. So when we're talking about defining a case for epidemiologic purposes, we really want it to be a simple definition, the most simplistic definition that covers the people that you want to cover. And we're going to talk in more depth about case definitions. You want it to be easy to measure, so you want to be able to quickly and easily identify the people that meet your case definition. That usually doesn't mean that you can give everybody a complex blood test, right? What it usually means, or for example, in the context of my research, I go into a large insurance database and I look for the ICD-9 codes for people that have a particular illness. Now, it's slightly more complicated than that, but that's kind of the general idea. You want it to be something that's easy to measure and easy to identify. And then your hope is that you will use a consistent definition across your entire study. Theoretically, you would like it to be across everybody that's studying this particular disease state. That's a little unrealistic. But you want to have a consistent case definition so that you know that everybody that you're calling a case in your study truly does have that illness that you're interested in. All right, which leads us to the actual term case definition. So a case definition really is our way to describe the health-related state of interest by identifying the who, when, and where. So we want it to be specific and unambiguous. Case definitions can be composed of the clinical criteria of the disease. They can be segregated into the clinical criteria plus it had to happen in a certain place at a certain time. The more specific you can be in your case definition, the better. The more likely you are to include the people in your study that you want to include and exclude the people that don't belong there. So, for example, the National Center for Health Statistics has a case definition for current adolescent alcohol use. So, the National Health and Nutrition Examination Survey, NHANES, is a nationwide survey that they sample people from across the population in the United States. They do this every year. And this is where the NHANES study is really where we get the rates of disease that are reported in on. When you look at the CDC and they're telling you like the prevalence of diabetes in the United States is this, it's usually coming from the NHANES data. So what they do, they go out, they don't just survey people, they actually do long, complex medical tests on all these people that end up in the sample. But in order to determine and report this information, they have to decide on case definitions for certain things. So, they have created a case definition for current adolescent alcohol use. And that case definition is adolescents aged 12 to 17 years who had at least one drink of alcohol in the past 30 days. So we have the person aspect, aged 12 to 17, the places in the United States. And then at least one drink of alcohol in the past 30 days. So that's the when, that's the time. That's a very specific definition, right? Now, whether or not you agree if that actually constitutes adolescent alcohol use, please note, if a 10-year-old drinks, that does not get counted in this number. If an 18-year-old drinks, that does not get counted in this number. The only people that are included as having adolescent alcohol use are people that are 12 to 17 years old and that had a drink within the past 30 days. So if they had a drink 2 months ago, they wouldn't get counted when we're talking about the incidence or prevalence of alcohol use in the United States. Now, the reason that's so important is because the goal is for us to be able to count the people that are sick, right? We want to be able to count the people that have a certain characteristic. In order to count them, we have to know who they are. So we have to define them. We define who we're looking for. That's our case definition. And then once we have created a specific definition, then we can count them. And our measures of disease frequency is just a really fun term for counts and specific rates of different types that we're going to talk about. But it's really just how we quantify the amount of disease within a certain group. Now, before we can really talk about that, we have to do some math review. There's not a lot of math in this class, but in order to remember kind of and to understand the concepts of measured disease frequency, we have to remember that a ratio is the division of one number by another number. Right? Everybody, that sounds familiar, vaguely familiar from like 3rd grade or something. A proportion is a type of ratio, but a proportion is where the numerator is actually a subset of the denominator. We frequently express a proportion as a percentage. And a rate is usually a proportion with time added in. So if it doesn't have some aspect of time, you cannot call it a rate. People will, but you should. So let's walk through what some of these. The count is simply the number of events, the number of things that happen, the number of people that are sick. So we have our case definition. We've decided that we have defined people with asthma as someone who walks into the ER, into the SLU ER, and has a previous diagnosis. I don't know, I'm making this up, and has a forced expiratory volume of whatever it's supposed to be. I shouldn't remember what it is, but anybody here have asthma and know what it is? Anyway, look, you're all healthy. Nobody has asthma. Great. Anyway, but so we've created our very specific case definition. And then we can say, when people walk in the ER, we can say, okay, we count them. If you meet this case definition, we throw you in the bucket of the count, and we say we've had 37 asthma admissions from the ER. That's just a count. We don't have any concept of time. We don't have any concept of out of how many people entered the ER. This is just the number of people. So the count doesn't really tell us a whole lot because it doesn't allow us to compare any information at all. The proportion, however, allows us to get a little more information. So now we're talking about the number of events that happen. Our count is the numerator divided by the population from which the events occurred. So our 3 asthma admissions divided by 300 patients that were admitted to the ER. So that's the proportion of patients in the ER that were admitted for asthma. Now we usually talk about proportions and percentages, right? So we could say 1%. Either way, however you report this, you can say if the proportion is 0.01, you can say the proportion is 1%. All of those are correct. There's just kind of standard things that people do. But mathematically, they're equivalent, right? But then that leads us to a rate. So now we want our count, the number of asthma admissions, divided by the number of patients that were admitted to the ER over some period of time. Because that's really what matters, right? We want to know how many, out of how many, out of how long. And so that's where we get to have the rate. So we know we had 3 admissions for asthma into the ER out of the 300 patients that were admitted to the ER over a 1-year period. So that's our rate. Now there's kind of just some standards with just in epidemiologic reporting. We typically express rates as whole numbers. So if we had 0.01 asthma admissions per ER admissions, we simply multiply that by some factor of 10. Different disease states usually use different factors of 10. I don't know why nobody likes to be standard. But so then we just get 1,000 asthma, if we multiply it by 10,000, we get 1,000 asthma admissions over 10,000 ER admissions per year. Because it's a rate, so we have to tell the time, right? There's really no reason except for the fact that 1,000 out of 10,000 admissions is a little more intuitive for most people, and so that's why it's reported this way, standard, just because usually it's easier for people to understand this number than it is for them to understand that one. All right. Now, when we really want to talk about the person, place, and time, we have to talk about exactly who we're talking about. So we have to define our populations, right? Because we care about, our population is who we really care about. So populations. Populations can be fixed or they can be dynamic. A fixed population simply means that no one is entering or leaving the population over the period of time that you're interested in. So if our population is the students in this classroom, unless someone adds the class or drops the class, this is a fixed population. No one changes. The same people will be in the population from the start of the semester to the end of the semester. A dynamic population, the membership of the population changes. So if we're talking about, for example, the population of Missouri. The population of Missouri is a dynamic population. People move into the state, people move out of the state, people are born, people die. The population changes. It fluctuates across time, right? So I used the example of the classroom for the fixed population. Now, fixed populations don't necessarily have to be something that's as small as this. Usually fixed populations are oftentimes something that's of a short duration and kind of not close, but geographically. So it would be a classroom or everybody that attended a picnic or people that were on an airplane at a certain time. But it doesn't have to be a fixed population so long as the membership in the population doesn't change. It can span long periods of time. So another example of a fixed population would be soldiers that fought in the Persian Gulf War that were monitored for cause of death for the next 25 years, so long as you could ascertain everybody that died throughout the whole thing. As long as you had complete data on that. You could monitor people for 25 years. You know everyone who fought in the Persian Gulf War. As long as you follow all of those people up, that's a fixed population. Now, if you lost 2 or 3 people along the way and were not able to follow them, then it would become a dynamic population because you wouldn't know what happened to everybody. Dynamic populations often are defined geographically. We've talked about how populations are frequently defined geographically, be they fixed or dynamic. However, it could also be defined by administratively. So participants in the Aetna healthcare plan. That could be our population of interest. So it doesn't have to be geographically defined. It just frequently is. All right. So we know our population, and the type of population we have determines the type of measures of disease frequency we can use, that we can calculate. So incidence is simply the number of susceptible individuals that get the disease. They are new cases of disease. An incident case is a brand new case. So it's someone who was at risk of having the disease and now gets the disease. A count of incident cases is simply just the number of new cases of disease over your period of time that you're interested in, right? And susceptible individuals does not include people that currently have the disease because they're not susceptible, right? If you currently have diabetes, you're not susceptible to getting diabetes, you already have it. So you can't be at risk and have the disease at the same time. Cumulative incidence is the proportion of at-risk individuals in a closed population. So this is the important thing. So a fixed population. You cannot calculate directly cumulative incidence in a dynamic population. So it's the proportion of at-risk individuals in a closed population who become incident cases over a certain period of time. So cumulative incidence is the easiest way for us to talk about risk. It's a direct measure of risk of disease. But you can only measure it directly if you're talking about a closed population. So if you have 40 people that went to a picnic and 15 people developed salmonella poisoning, you had 15 new cases of salmonella out of your 40 people in your defined population. So that's your cumulative incidence. So it's difficult, most populations aren't closed. Most populations are dynamic. And it's difficult to estimate, you can't estimate risk directly using cumulative incidence when you have a dynamic population, especially when you're talking about long periods of time. So remember, dynamic populations are populations where people are changing. It's not the same people. So the majority of the people are the same, but some people move in and some people move out. So because we can't count and have a whole number of the absolute number of people that existed in this population over a particular period of time, because the number kind of fluctuates. So if we're talking about the period of 1 year, the population of Missouri changes probably daily. So we estimate person time. Person time is the amount of time a particular individual contributes to that population. So the amount of time. So if you only live in Missouri for 6 months, you contribute 6 months of person time to that entire year. If you live in Missouri for the whole year, then you've contributed 1 year of person time. But using person time allows us to estimate the incident rate. So we use incidence rate when we're talking about dynamic populations. And incidence rate is simply the number of incident cases over the amount of person time. All right, so how do we compute person time? Like I said before, you count only the amount of time that a person actually spends in the population during your defined study period. So I'm not going to make you calculate person time in here. You don't have to do it. I just want you to kind of, in general, see how it is. So, but the total person time for a study is the sum of each individual's time at risk. So, and remember, time at risk is time spent when you don't have the disease. So once you have the disease, you no longer contribute person time to the study. All right, so let's look at this. I think graphically it's a little bit easier to see. I'm missing an arrow. There should be an arrow right here. Sorry. So person A enters our population in January and leaves in December, or like is still disease-free in December, and we only have 1 year in our study period. So that person has contributed 1 year of person time. Person B starts in January, but in November they get the disease. So they contribute 3/4 of a year of person time. Maybe it's October. We can do a block. Person C starts in January, but in April they drop out of the study. We just lose track of them. But they only contribute 1/4 of a year of person time. And person D doesn't actually get into our study until April, but then they finish out the year. And person E doesn't start our study until September, and then they get the disease in December. So they contribute another 1/4 of a year. So we have 5 people that were in our population at some point in time, but we only have a total of 3 person years. Because each person only contributes time to the amount of time that they were actually included in that population. So incidence rate is simply the number of incident cases divided by the amount of person time. And then again, we usually report this, we multiply it by some factor of 10 so that we can report it in whole numbers. Now, incidence, like I keep saying, but I'm going to repeat it again because you have to remember that incident means new cases, because prevalence means existing cases. So at any point in time, you can count the number of people that are currently sick with a given disease, and that is your prevalence. Now, prevalence is a proportion, it is not a rate. Anybody want to guess why it is not a rate? Right, it's not over a period of time. It is calculated at one point in time. Now, you may hear it, sometimes you'll hear point prevalence, so you may count your prevalence as a day, or you may have a period prevalence, so it was the prevalence for a 3-year period, but it would count anybody that had the disease at all in that 3-year period. But because it's not a rate, it's not over 1 year, it's a point in time that we're counting the number of people that have the disease. Yeah?
So if you're doing like incidence over, I don't know, we'll just say a year, and someone gets the disease, gets better, but then gets that disease again. So like with that, would you count them twice in incidence but once in prevalence?
It depends. So it depends on your case definition, basically. So if your case definition, if the person gets the disease and then goes back into the at-risk pool and you're okay with counting that person as another incident case over that 1 year period, then yeah, you count them twice as incident and once as a prevalent case. But if you had a disease like that, an infectious disease, you wouldn't be counting prevalence over a 1 year period, generally speaking, if that was like a possibility. So, yeah.
So it's just kind of like the age thing.
Yeah. But the big important thing is that it's anybody that's sick. It doesn't have to be, it could be somebody that got sick 10, 15 years ago. So prevalence becomes really important if you study chronic illness. Incidence we care about for chronic disease, but we also talk about incidence a lot in infectious disease, and so there's slight differences in that. But when we're talking about chronic illness, people would probably only be an incident case once, and it would be a prevalent case subsequently. All right, so let's walk through and guess prevalence or incidence. Actually, let's not, we don't have time. Yeah, we definitely don't have time, it's almost 4 o'clock. Let's write this down and then you can, if you have questions, we can talk about, right? The first one is incidence. Specifically, it's incidence rate. Second one is prevalence. Third one is trick, but it's prevalence. And fourth one is cumulative incidence. Anybody want to guess why the third one is prevalence and not incidence when you're talking about the number of babies born? Yeah.
Because they have the disease, they're born with the disease.
They are born with the disease. The other, so they are born with the disease. At some point you have to like have an incident thing, but we don't know the number of conceptions, right? We don't know the number of abortions. We don't know the number of spontaneous or otherwise. We don't know a lot. So anytime you're talking about birth defects, it's always considered prevalence. It's never considered incidence. All right. Relationship between prevalence and incidence. Prevalence is equal to the incidence rate times the duration of disease. So a disease that has a low incidence can have a really high prevalence if people stay sick for a very long time, because you just essentially keep adding cases, right? So I heard somebody describe it as kind of like you have a big bucket and a drip of water is going into the faucet. So the drip can be very, very slow, but if the water never drains from the tub, you have a long duration of disease, eventually the tub fills up. And so you can have a high prevalence, but a very low incidence. Now, if you have a disease where the duration is really short, wait, I said that backwards, didn't I? Yes. You have a low incidence and a high prevalence. I'm sorry. I said that backwards. You guys know what I mean. But so if you have a short duration, you have a really low prevalence but a high incidence. So like the cold. A lot of people get sick, right? But they don't stay sick very long. So the overall, like at any given point in time, there's not a huge number of people that are sick, even though a lot of new cases keep coming about because people don't stay sick very long. Start back up with measures of comparison. So we talked about incidence, we talked about prevalence. Incidence and prevalence are great if they give us no real comparison between two groups, right? You can just say, oh, all of these people, new people got sick, and oh, all these people are sick. But what we really wanted to be able to do is make comparisons between subpopulations. Remember last week I was talking, I guess it was last week. I was talking about how the epidemiologist really gets excited when they talk about differences between subpopulations. And so we have to have some type of measure of comparison to be able to make these statements. So, we use measures of comparison to summarize the relationship between the exposure and the disease by comparing at least 2 measures of disease frequency, sometimes more. So we usually have group 1, which is our group of interest, and then group 2, which is our comparison group. We may have more groups, but we have to have at least 2. We have 2 options for comparison. We can either calculate the ratio of 2 measures of disease frequency, Or we can calculate the difference between two measures of disease frequency. My preference is to do the top one. They serve different purposes. We're going to talk mostly about ratios in this particular course, rather than absolute risk difference. All right. So we've learned how to calculate incidence. We've learned how to calculate prevalence. We've talked about the difference between fixed and dynamic populations. Let's talk about what types of measures of disease frequency we have. A crude rate is the rate for the entire population. So if you say that's crude, that means everybody. We haven't taken anything into consideration. We haven't partitioned anyone out. We haven't statistically manipulated it. Everybody's included in the crude rate. A stratum is simply a fancy word for a subgroup, right? So your stratum could be, you could stratify based on race. And so your stratum would be white, or non-Hispanic white is usually, you have to do the race ethnicity thing. Non-Hispanic black, Asian, so forth, right? Or we could stratify based on gender. So we would have two strata. We would have women and we would have men. So once we have stratified, once we have grouped people into their little subpopulations, we can calculate a stratum-specific rate. So the stratum-specific rate simply means the rate for just that subgroup of the population. So if we have a stratum-specific rate, we can then say, okay, we know the rate for women is this, but the rate for men is this. And then you can start talking about making comparisons between women and between men and men, right? On disease state. An adjusted rate is a rate that we have mathematically manipulated so that we minimize the differences in populations. So we're not talking about now making comparisons between two subpopulations. We're talking about we have taken all that we know about math and we've taken out the variance due to some other factor. And now what we're hoping to do is just isolate the rate that's due to whatever we're interested in. We will talk about adjusting rates a lot more in the future. But let's walk through. So if we're talking about measures of disease frequency, if I tell you in 2007, 10.7% of people aged 20 and older in the U.S. had diabetes. What is that? It is a crude estimate of prevalence. So I guess maybe the rate was a little tricky. Yes, so it's prevalence. Prevalence is technically not a rate, but it is the crude estimate of prevalence because it's for everyone in the entire population at one point in time. So this doesn't tell us anything about how diabetes is distributed amongst age groups. It doesn't tell us anything about how it's distributed amongst gender. All it does is says out of the entire population of the United States, this is how many people have diabetes. But when we're talking about descriptive epidemiology, we want to know the patterns. We want to know the patterns based on person, place, and time, right? And so that first number, just the general overall crude prevalence, doesn't give us any information about person, place, and time. Well, it tells us about time, because we know it's in 2007. But it doesn't give us any information about the who or the where. So we can stratify. We can stratify based on any factor that you can imagine, so long as you have that information, right? To stratify, we just simply put people in their separate pots. Epidemiologists like to categorize. It's their favorite thing to do. They like to stick everybody in little check boxes. Put them in their little box and make them stay there. I am also a social worker, and social workers hate to stick people in little boxes, so it's really this very weird juxtaposition for me. But anyway, as an epidemiologist, we like to put people in boxes because it's very nice and neat. And so we can stratify. So if I want to create a stratum-specific prevalence, and I'm interested in stratifying by gender, I then just take all of the women in the population and throw them in the women box. And I take all of the men in the population and I throw them in the men box, and that is stratifying based on gender. I can now calculate the prevalence just in the women, right? So the denominator, when I'm calculating prevalence, is not everybody in the whole population. The denominator is just the total number of women. So I have the number of people who have diabetes, the number of women who have diabetes out of everybody that's a woman in our population in 2007, right? Or I can do that for men as well. So now we're starting to get information about person. We're able to make comparisons between women and men, right? We could do this with any other variable that you can divide people up into groups by. But it's giving us information about the disease frequency relative to person, place, and time. And when I say stratum, I simply mean subgroup of the population, right? Stratum is just a fancy word we like to use for it. So here we have the prevalence of diagnosed and undiagnosed diabetes stratified by age. So we have taken age groups, and we have said we're going to look at the people that are 20 to 39, we're going to look at the people that are 40 to 59, and we're going to look at the people that are over 60. And you throw everybody in their particular bucket. And now that we have stratified, remember that it was a 10.7% prevalence in the United States. Well, now that we look at it, we say, oh my goodness, people that are old are much more likely to have diabetes, right, in our population. If you're over 60, 23% of the population in 2007 had diabetes. 23% of the over 60 population, excuse me. But only 2.6 of the population that's under 39, between 20 and 39 had it. This is a lot of really interesting information, right? So if we're trying to figure out where we're going to spend our money to try to prevent diabetes or to try to help people with diabetes from getting other problems that are associated with diabetes, we may want to spend our money on people that are 60 and older, right? So we can also look at it in a table form. Just simply, we've stratified adults with diagnosed diabetes in Missouri in 2007, so we're still looking at prevalence within Missouri. So at this point, we have now actually created two strata. So if our first population was the population of the United States, we can stratify based on state, right? So we can look at within Missouri. We compare Missouri to Illinois. And then within our Missouri strata, we can also stratify by age again and look at the prevalence, the age distribution within Missouri. And if we really wanted to, we could look at the age distribution within Missouri and compare it to the age distribution within Illinois, right? So you can keep breaking down into subgroups depending on what your interest is. Now we're talking about place. Now we can look at the distribution of diabetes within Missouri geographically. Yes?
If you were comparing like Missouri and Illinois, would you have to adjust the rates to be like a similar amount?
Yes, but we're not there yet. We're
Okay.
2 slides ahead. Yes, you do have to adjust. You have to make comparisons based on characteristics of the baseline population. Now I lost my thoughts. No, it's fine. It's a good question. It's an excellent question. So we want to look at county level estimates, right? So now we're looking at the geographic distribution of the prevalence of diabetes within Missouri. So you can see there are certain counties, the Boot Heel, lots of people are sick down there. Now none of this tells us anything about why these distributions are, this is just telling us what's going on. So we can see that different amounts of people are sick based on where you live. Then we can look at time. We can look at time trends of diabetes, right? So we can see over time, the prevalence of diabetes has been increasing. And it has not leveled off. This only goes to 2008, but it's still going like that. We got a lot of diabetes in the country. But this particular graph actually gives you a crude rate and an age-adjusted rate. We're going to talk about age adjustment in a second. But so this is out of the entire population of Missouri. It's not stratified by anything. It's not making any comparisons. It's just saying the little blue dot is the actual numbers, the number of people that had diabetes within Missouri at that particular point in time. All right. Now here's the deal. Why do we care? Because we can identify people who are more likely to get sick. We can prioritize where we're going to spend our money. We can also learn something about the potential causes or risk factors for a disease based on how it's distributed within the population. So we saw when we were looking at the geographic distribution of diabetes, we saw that there were a lot of people in the Boot Hill. The prevalence of diabetes was a lot higher in the Boot Hill than it was in like the St. Louis area. And then we can think about why might that be the case? Because that's really what we care about, right? Is why are these people sick? It's like, it's great to know that more people are sick there, but we want to know why. And so we can start to hypothesize why. Maybe more people are overweight there. Why are more people overweight? Maybe there is no place for them to get out and exercise, right? We can come up with these hypotheses, and these are hypotheses that we come up with based on our descriptive epidemiology are then things that we can test so we can learn more about the causes and risk factors of disease. But we can't ever get to that part if we don't know how the disease is distributed within the population. All right. So how do we account for these differences? As I talked about earlier, we can compare stratum-specific rates, so we can stratify everybody and then we can make comparison between those groups. Or we can adjust our accrued rates. Now, remember when I said an adjusted rate, that means we're mathematically manipulating it. So we're taking out the effects of the third factor. We're essentially leveling the playing field so that the only thing that we see in the numbers is the factor that we're interested in. So whether or not you use stratum-specific rates to make comparisons or you try to adjust your accrued rates depends on the goal of your research. If you really are interested in comparing men and women, you don't want to adjust for gender. You don't want to take gender out of the equation. You just want to know, are more women sick than men, right? Adjusting accrued rates, because we're mathematically manipulating them, the resulting rates are technically hypothetical. They don't represent the actual disease frequency, but they're more meaningful if you're trying to make comparisons between groups that